Thank you. It's so nice to be here with all of you this morning. And as you know, we're going to be talking about serving people with behavioral health challenges during disasters. And this is really, when you look at the literature, you really don't find a lot about this particular topic. So it's really going to be a very interesting, productive day, I think, to start this process of working together and thinking about these issues. Let's see. So throughout this presentation, we're really going to be looking at three primary aspects. Who are we talking about, what are we talking about, and how do we get there? And so when we talk about the who, we're focusing on, as I mentioned, people with behavioral health challenges. In terms of the what, we're looking at what are those reactions that people with behavioral health challenges exhibit, and what are their needs during at the time of disaster, during notification, evacuation, sheltering, and response. And in terms of the how, this is the difficult part. How do we address these needs? How do we come together as organizations and really begin to address these needs? And that is kind of the hard part. So we're going to be looking at some lessons learned from previous disasters. We'll look at some findings and recommendations from experts in the literature, and some other recommendations. So when we talk about disasters, we're going to start by talking a little bit about the impact disasters have on everyone who's affected by them, and what the risk factors are, so that we can kind of have a shared understanding of how disasters really affect people. Fran Norris from the National Center for Post-Traumatic Stress Disorder defines a disaster as a sudden event that has the potential to terrify, horrify, or engender substantial losses for many people simultaneously. So traumatic events will naturally cause many people to experience typical and expected reactions. And some of those people, a percentage of those people, will go on to experience more serious distress and even PTSD. But in those early days after a disaster, we don't expect people to exhibit signs of PTSD, but we may actually expect them to show some other reactions, and we're going to talk about those in a couple of minutes. So all disasters, when based on that kind of a definition, it's understandable then that all disasters require a behavioral health response in order to maximize opportunities to promote resilience and recovery. In the past, over the past 10 years, more than 10 years since 9/11, there's been a lot of research and a lot written about how the general population responds to disasters. But not much has been written or researched about people with behavioral health challenges and how they respond to disasters and what we need to do to prepare. So this is really groundbreaking work that you all are doing here, and it's exciting, and it's going to be important for you to kind of be role models and help other communities figure this out. So when we look at this chart, what we see are the phases of a disaster, from the pre-disaster, which includes the warning and threat phase, to impact, and then recovery. And along this continuum, we could see the collective reactions. Those are the reactions of the communities, how communities respond. So shortly immediately after the impact, we see this heroic phase where people are really joining together, and there's a lot of energy, and people are helping each other. After that, we see this period of this honeymoon period of community cohesion. Then there's this long period of time which we refer to as disillusionment. And this is a period of time where people are starting to feel really frustrated. Sometimes it's because of the slow pace of rebuilding. And then people start to move into this upward motion, which is towards reconstructing their communities. As communities rebuild physically, so too are people rebuilding or recovering emotionally and psychologically from the effects of the disaster. So there are certain events that are taking place throughout the process, starting with just prior to the disaster, that cause a lot of stress. And of course, this is going to be true for the general population as well as people with behavioral health challenges. So during evacuation and sheltering, we're going to see higher stress, death notification, reopening of public facilities, and certainly the anniversary, the one-year anniversary, and sometimes additional anniversaries after that, we're going to see a spike in people's reactions. We talked a couple of minutes ago about the fact that we expect people after a disaster to have certain reactions. These reactions fall into these 4 domains: emotional, behavioral, physical, and cognitive. So when we think about the emotional reactions, most of us are familiar with these. It's shock, disbelief, anger, guilt. Why did this happen? Why did this happen to my neighbor and not to me? Certainly in tornadoes, we see the neighbor's house is gone and my house is still standing and nothing happened to us. And oftentimes we see this reaction of guilt. Behavioral reactions are actually very common, particularly people complaining of stomach aches, headaches, and most of the time people don't realize that those reactions are actually associated with the experience, this traumatic experience they have had. And they're going to show up in their doctor's offices and clinics, and they may be sitting in the shelters talking about these kinds of things. And in kids, too, we see them complaining about stomach aches and perhaps headaches. Physical reactions include rapid breathing and I think I just talked about the physical reactions, didn't I? So that also includes rapid breathing and sleep disturbances, sometimes eating disturbances. When we talk about behavioral reactions, we're talking about irritability, agitation. Sometimes in kids we see them regressing in terms of their behaviors, and this is where we categorize substance abuse and substance use issues is via behavioral reactions. There are also cognitive reactions after a disaster, and those, when we're talking about cognitive reactions, we're talking about poor concentration, forgetfulness. People will start to complain that they can't remember things. They may not even have a memory of the event. And we do consider these reactions to be somewhat normal in the early weeks, early days and weeks after the disaster. The people that we're most concerned about following a disaster are people who are at risk, the people who are at risk for more serious reactions, more serious distress, fall into these categories. Certainly people who were injured, or the family members of people who were injured or deceased in that disaster. Rescue recovery workers, volunteers involved as first responders, people with low socioeconomic status, people with few or no supports, like single women, single moms. They're most at risk for developing some additional distress and stress. People who have had multiple losses, and certainly we're talking here in this conference about people with pre-existing behavioral health challenges, as well as people with pre-existing trauma, and of course people with physical and cognitive challenges as well. This is important. It's important to understand because when we're making decisions, especially emergency planners, emergency response folks, making decisions about how to spend, target the dollars and the resources that are usually quite limited, it's important to kind of have an understanding of who are those people who are most at risk for developing adverse reactions. So when we talk about who, we want to talk about how do we recognize people with pre-existing behavioral health challenges. We're going to look at the prevalence rates, what are behavioral health disorders, the challenges for people with more serious mental illness, and risk factors for them. And so when Holly was up here earlier, she talked to you about the fact that 1 in 4, I think she mentioned 1 in 4 people in San Diego have a diagnosis of mental illness, and that's in keeping with the U.S. statistics. So amongst the U.S. adult population, 26% of people will experience a mental disorder in a given year. And of that number, 25% of those people with mental illness will also have a co-occurring disorder of substance abuse. Also, of the U.S. population, 5.6 are diagnosed with having a serious mental illness. And so they're a smaller population, but they require much more care and have more needs. I talked a moment ago about people with pre-existing trauma. And again, what we see here are really staggering statistics, absolutely staggering statistics. So when we talk about people who have been in the mental health system, in this case we're referring to women, 55 to 95% of women in substance abuse treatment report a history of trauma. When we talk about women in the public mental health system, we're talking about 85 to 95% of those women saying that they have a history of trauma as well. And then even in the general population, there are 2/3 of people who have experienced some adverse childhood experience. We know this from the ACE. This is the Adverse Childhood Experiences Survey that was actually done here in California by Kaiser Permanente and the CDC a number of years ago. But it was kind of the first of its kind to look at the general population and try to figure out whether or not people in the general population have had these difficult childhood experiences. And note, we're talking there about sexual abuse, physical abuse, or witnessing violence in the home, those kinds of things. So we know then that the people we're going to come across in shelters, people with behavioral health or substance abuse issues, are likely to have previous experiences with trauma. And we're going to talk a little bit about what that means in a shelter situation. And even the people in the general population may have had experiences with trauma as well. So when we talk about behavioral health disorders, what we're talking about is just mental health as well as substance abuse falls under that heading of behavioral health disorders. When we talk about people who have, one person who has both a mental illness and a substance abuse problem, there we're talking about a co-occurring disorder, okay? And when we talk about mental illness, we're talking about a range where it could be very mild to more severe. Anxiety disorders, which are considered mood disorders, depression. Anxiety is really the most common type of mental illness. And also alcohol use disorders are most common amongst substance abusers. So we talk about anxiety, depression as being a mood disorder, and I know Lynn talked earlier about thought disorders, and that's where you got into more serious mental illness, where people, for instance, the diagnosis of schizophrenia, where people are experiencing voices, they're hearing voices, and they may be delusional, which means that they have a certain belief system that isn't true. Some people believe that there are messages coming from the TV telling them what to do. So that would be an example of a person's delusions. And of course, you know, those folks in a shelter situation might be saying things that don't make sense. And certainly that might be a symptom that this person may be experiencing delusions or hearing voices. One of the things that's really important to note is that people do recover. People do recover from mental illnesses, mild mental illness, all the way to more severe mental illnesses. They do recover. And there's a lot, we're going to talk a little bit more about the peer support movement, and that's one of the really kind of wonderful things that are coming about in the field of behavioral health, where there's more peer-to-peer support, and we're finding that that's really a very good way to help people recover from mental illness, but also after disasters. So we'll mention that a little bit further on. So I mentioned in serious mental illness, those are less common. However, those folks do require more care. So when we look at the challenges that face people with more serious mental illness, it's important to kind of understand these because they're going to be important in terms of planning for folks before or during a disaster or after a disaster. So a lot of folks will be dependent on the system for care. And now we're talking about people with more serious mental illness. They're going to be dependent on the system for housing, services, support. They may not have any family support. They're often unemployed. They may be undiagnosed in the community, and they may be having symptoms of their illness. They may not be on any kind of medications. And as I mentioned, they may be actively psychotic, hearing voices, or experiencing delusions. And so, in addition, those folks often don't have cars, they may not have cell phones, and so it's really important to kind of figure out how are we going to communicate with these folks to get them, and they may be living in the community independently. They also may be homeless and living in areas that, we may not see. And so it's really important to try to figure out how are we going to reach those folks to make sure that they're safe, and how are we going to provide transportation for people who don't have access to cars. So when we talk about pre-existing mental illness, we want to think about what places those folks more at risk for having some adverse reactions, more serious trauma reactions. Of course, just as in the general population, when they have major losses, disruption in their typical routine, as well as interruption in their treatment, this places people with serious mental illness more at risk for developing these more adverse reactions. When we talk about people with pre-existing trauma, when exposed to a disaster, people with trauma histories are at higher risk for re-experiencing the original trauma. So if you come across someone who seems to be experiencing PTSD, they have a heightened startle reflex, they may be preoccupied with the traumatic event, hypervigilant, it is likely that they may not, unless this has been a very, very traumatic experience and they were very close to the event, it is likely that they could be re-experiencing an original trauma, an earlier trauma, and as well as the trauma that they've just experienced in terms of the disaster. Increased stress and this re-traumatization often leads to increase in the use or abuse of substances. And so we have to keep that in mind. And of course, that's something that could really create problems in an evacuation situation, in a sheltering situation. How do we manage people who may have, maybe they were in recovery or maybe they are actively using. So at this point, we're going to talk about the what. What do we need to know in order to identify and assess needs and triage care? So we're going to look at the similarities to those between people with behavioral health disorders and people who do not, people who are in the general population. During notification and evacuation, we're going to look at the reactions and needs, shelters and mass care sites, in individual sheltering in place, and what are those universal needs that affect everybody. So when we look at, it's important to kind of look at how people with behavioral health challenges are going to react in the same way everybody else. And there are many people who will. And one of the things to keep in mind is that people with pre-existing behavioral health challenges, as we mentioned, often have previous trauma histories as well. Well, they're more experienced in dealing with and coping with adversity and challenging kinds of situations. And so because of that, they're actually, many of them are going to be able to handle a disaster situation in a very good way, in a way that's resilient, and they're going to be able to bounce back pretty easily. They have the same reactions, they have the same need to express themselves, and they also have the same need for safety, stability, food, shelter, and support that everyone has. They're also going to have the same difficulties everyone else has in terms of maneuvering through the system in order to get the support and the help they need. So when we talk about reactions and needs during notification and evacuation, I wanted to highlight some of those more those other types of reactions people with behavioral health challenges may be exhibiting, so that you would be able to recognize those. Some people, in terms of the warning, may not be able to hear a warning announcement. They may not be able to understand it, particularly if they're hearing voices or they are delusional. They may be isolated and not connected to media outlets, and also they may refuse to leave their home. So, as Lynn was talking about earlier, the same kinds of approaches are really important. To talk to people, and this is really true for all of us, to talk in a very calm, reassuring manner is really going to work. And as I said, that's really going to work for every single one of us, isn't it, after experiencing such a traumatic situation. The other thing that's kind of important is not to get into people's space, but to kind of allow them some distance between you and them, and to really provide the appropriate information. So we talk about shelters or mass care sites. What we might see are isolating behaviors, people kind of standing off to them, kind of to themselves, off to the side. We may see more agitation, anxiety, and distress. We may see some exacerbation of the symptoms of their illness. Okay, so if they have an anxiety disorder, they may become more anxious in that situation. Or even if they were experiencing hearing voices earlier, those were treated with medication, going through that kind of event could create that situation where they're experiencing those symptoms again. People may have those kinds of cognitive reactions we talked about earlier where they may not be able to recall their own name, they may not be able to tell you what their diagnosis is or what kinds of medications they're on. And again, it's going to be really important to kind of give them some time and space to be able to calm down, to feel safe in that situation, and then at some point they should be able to provide that kind of information. When we talk about individuals sheltering in place, I think generally speaking, we're going to be talking about people who really haven't developed a plan for how they're going to manage that situation. They will most likely not have the basic supplies that are needed, flashlight, radio, perhaps those kinds of things, especially if the electricity is out. They certainly would have a lack of medications, and they'd be disconnected from their treatment services. And again, we might see increased anxiety, agitation, distress, and with people living alone, that could be a really difficult situation where they would continue to be isolated. Universally, what all of us need after a disaster is to have physical, psychological, and emotional and tangible needs met. And physically, we're talking about the need for safety, comfort, quiet, caring environment, okay? We all need those things, and certainly people with behavioral health challenges need those as well. Psychological and emotional needs are reconnecting to treatment services and support services. They need information and safety about our loved ones, and this is true even for people with behavioral health, physical, any kinds of cognitive challenges. They too need to have an understanding of what's happening with my loved ones. Is everybody safe? Is everybody okay? And they need to have that kind of information and education about what's happening. So when we talk about these needs, the sooner responders can get to people, and I know the Red Cross does this really, really well by setting up shelters immediately following the disaster and having mental health folks available. The way that we can really promote resilience is through these ways: a sense of safety, calm, connectedness to others, and a perception that I'm able to manage this, I'm able to cope, and a sense of hope. I'm going to have to move a lot more quickly here. We talk about how do we start addressing these needs? That's kind of the big question. We're going to look at lessons learned and what is found in the literature and what are the experts saying. So I'm going to move over to this summary and talk to you about what we know from the experts is that in times of evacuation and sheltering, behavioral health providers, and this is why it's really important, and we're going to talk a little bit more about this, to collaborate, and as all of you are doing by meeting together here, and I understand you meet regularly. Collaboration is really a key element, because coming together and partnering with American Red Cross, for instance, consumers should never be separated, and we talked about this earlier, consumers should never be separated from family caregivers, even their service animals, service dogs if they have one. And it's important for shelter staff, evacuation persons to anticipate and plan for appropriate shelters, medications, methadone for people who are substance abusers, and as I mentioned, allow for pets. Communication is another really important thing that we've learned from previous disasters. And one of the things I wanted to point out is that in New York, one of the most important things that they learned is peer-to-peer support was extremely beneficial. So we found that within the fire department, where firefighters were going out and working with their peers to help them cope with the situation that they had just experienced and that was ongoing. Police to police, and certainly also consumers of behavioral health services reaching out to other consumers. That video Lynn showed earlier was really wonderful, and something that I think we need to really do in the behavioral health field, and I'm not sure anything like that really exists. Let's see. So I'm going to skip over some of this and move on to, when I looked at what the experts are saying, like experts from Johns Hopkins and Yale University, as well as what the literature talked about, we could categorize their recommendations into the following: planning, collaboration, training, communication, and response. And so in terms of planning, it's really important to think about, and this is what one of the experts referred to, planning for behavioral health consumers. It should really be done in the same way that you would plan for people who were physically injured in a disaster. The other thing that's really important in terms of planning is helping consumers of mental health services develop a disaster kit, and that's one of the things that Lynn talked about earlier. And the same thing holds true for people with behavioral health challenges. I'm not sure much is going on. Maybe certainly in disaster-prone areas, more is happening on the behavioral health side to help consumers develop those personal care plans, but those are really important. In terms of collaboration, what we hear the experts talking about is emergency management, sharing disaster emergency preparedness materials with behavioral health providers, and peer groups, as I mentioned earlier, can be very important during planning and response. Collaboration just can't be stressed enough. This is really the key. Having those relationships prior to a disaster is really key to whether or not you're going to have an effective response and really reach the people you need to. And certainly being able to sit together and identify and anticipate what those needs are is going to be helpful. Training is another important component, and the cross-training between behavioral health, emergency management, VOADs could be so extremely helpful. One of the things that, when we talk about training emergency medical technicians, perhaps even volunteers, there is a training program called Mental Health First Aid. This was brought to the United States by people in Australia, people in Australia developed this mental health first aid, and it was brought to the U.S. by a number of organizations. And what it does is really teaches lay people how to recognize signs of mental illness or substance abuse, and not only recognize those signs, but learn how to approach someone in that situation. What can I say? What can I do? And it's a very interactive training and process, and so you come away from that experience really having a better understanding and kind of reducing people's anxiety about approaching someone who has a behavioral health disorder. Communication is obviously another really important one, and what the experts say is use volunteers to distribute material to, throughout the community, use the media in order to reach folks with behavioral health challenges, and also be creative. So for instance, in Joplin, Missouri, after the tornado, they were using yard signs, putting up yard signs to give out information about where people could go for help. In New York, they used billboards and they used subway posters. So really important to do that. In terms of response, we talked earlier, again, I want to stress that using peer organizations, established peer organizations, or using peer groups to reach out to other peers is really going to be most effective. They may know where the homeless population moved to during or after the disaster. They're going to be a trusted person to them. They also have that same lived experience, and so they can be extremely helpful partners in this process. And that moves us into key partners. Of course, emergency management, first responders, behavioral health provider community, American Red Cross and other VOADs, and as I mentioned, these peer support groups. Also within the behavioral health community, we're talking about consumers themselves, getting them involved in helping you plan, using case managers, assertive community treatment teams, and caregivers, as well as the National Alliance on Mental Illness. Family group could be very helpful. Behavioral health providers play a really important role in reaching people with behavioral health challenges. We have to remember that they have a very large population of people to serve. Generally speaking, they're responsible for their own consumers, and those people could be in psychiatric hospitals, group homes, they could be living independently, and they're also responsible for their own staff, ensuring their safety, and also they're helping them to cope with that situation, okay, providing that kind of psychological first aid that we provide after a disaster. They're also responsible for the general population, the survivors of the disaster, and for oftentimes for helping first responders to cope with the challenges they're facing. So when we talk about the behavioral health providers, they really have a lot on their plates, and so they also are mostly in situations where there are shrinking dollars, shrinking staff, there are more needs that they're trying to respond to. And so their time availability in terms of planning and attending drills and doing this cross-training we're talking about certainly is a challenge. And certainly during a response, they may be overwhelmed. But that doesn't mean that they shouldn't be involved in these planning efforts. So some of the, I'm going to kind of move through this one. And so what we're talking about here is developing integrated plans where emergency management, behavioral health folks can come together and have plans that really match with each other and are really going to be helpful in responding to this population. They need to collaborate with each other as well as those other key partners we mentioned. They need to train and cross-train staff, engage in joint drills and exercises, and certainly coordinate response efforts. And so what are the key messages in terms of planning for people with behavioral health needs? We need to integrate and coordinate planning and response efforts, as I just mentioned, through outreach. It's not okay to just sit there and say, well, those behavioral health folks aren't coming to the table. Well, reach out to them, knock on their door, and help them to participate. collaborate with a variety of behavioral health entities, as we mentioned, NAMI and those peer groups, train planners and responders, including volunteers. That mental health first aid could be a really worthwhile tool. The other thing you have to keep in mind is, at the time of a disaster, if there's a major event like an earthquake, you might need to do just-in-time training, which means you want to have a training tool available to you to use at that moment. Be knowledgeable about resources, develop effective communication plans. This is a way to even start the resilience building, is the way that you're putting out messages to the community and what you're saying. Develop appropriate evacuation procedures and ensure that shelters are accessible and appropriate for all, and of course promote resilience. A couple of tools. I know Dr. Schreiber is going to talk about an intake and assessment tool. Perhaps he's going to refer to this tool that was developed by Health and Human Services and American Red Cross after Katrina. But it is a very simple tool that gets at people's specific needs. It covers physical, cognitive, as well as behavioral health needs. And the other tool that could be very helpful in when we're talking about populations, vulnerable populations like people with behavioral health challenges, is to develop a registry where people could voluntarily agree to have their information in a database that could be accessed at the time of evacuation. How do we find these folks? Where are they? Maybe matching them to their caregivers if they were separated. And so I listed there Fairfax County in Virginia who have started using this approach. There aren't many people in the country using it. You may want to consider this. I've just listed a couple of resources and also federal behavioral health resources. I think you know that FEMA has the Office of Disability Integration and Coordination. They have local people as well, regional people. Substance Abuse and Mental Health Services is the agency I worked for 10 years, and they have a Disaster Technical Assistance Center that is available to provide tip sheets and TA, all kinds of information is available through them. I am going to end now because I probably went over my time, and thank you so much for your attention.